Hello. So we will discuss again today skin cancer. No, it's not here yet. Okay. This is a cut in the skin, and basal cell cancer originate in the interfollicular basal cells or keratinocytes in the hair follicle or sebaceous glands. Usually these are slowly growing tumors, and the cells appear histologically very similar to the original cells. Clinically, they may present either as a non-healing sore or a patch or a scar that doesn't change for a long time or a shiny bump. By far, these are the commonest skin cancer, comprising almost 80% of all skin cancers, yet the risk for metastasis is very small, less than 0.5%. There are several risk factors known with the BCC. Some of them are phenotypically with fair hair and skin, some are related to exposure to carcinogens, and some are related to genetic abnormalities like DNA repair problems or the nevoid basal cell carcinoma, the one at the bottom, which I'll discuss a little bit more, the Gorlin syndrome with a mutation at the patch protein. Also, recipients of solid organ transplantation are exposed to high risk of basal cell cancer. So for most of the patients, surgery is the most appropriate treatment, with over 95% of 5-year control rate, and with most about 99%. But for some of the patients with locally advanced disease, or some of them, surgery may be debilitating or disfiguring. Surgery is not the appropriate thing to do. So you can see also here a patient with a very big basal cell carcinoma, or if the location may be disfiguring with big operation, and very small minority of patients with metastatic disease. In the Red Journal in 2004, there was a description, retrospective analysis of patients that were treated with radiation therapy to their tumors, patients with squamous cell cancer and BCC, and you can see that at 5 years, at 60 months here, the disease control rate was over 80%, 86% for these patients being irradiated. Of course, these are the non-modern techniques of radiation. Maybe these may be even higher for locally advanced disease. So we see it basically as a pyramid, with the highest percentage of patients who are amenable for curative surgery, the minority with locally advanced disease, either for surgery or radiation or other means, and the very small minority with metastatic basal cell cancer. In 1980, Nuslin Volhard reported the pathway, the hedgehog pathway. Later, in 1995, he and his colleague were awarded the Nobel Prize for the description the hedgehog pathway. They investigated mutated larvae, mutated embryos of the fruit fly, the Drosophila, and they noticed that these mutants, which were shorter and like spiky hairs, therefore they called the pathway the hedgehog pathway. So they discovered the pathway which controls mainly embryonal development and mostly is inactive in adult life. The pathway controls both proliferation and polarity of tissue, and therefore some of the adult flies could present with malformation of the eyes. You can see this is the normal phenotype, and all these phenotypes are either lacking one of the eyes or have disfigured eyes. Also, there may be changes in the teeth. Okay, you can see here a child with disfigured central incisor due to mutation in the hedgehog pathway. Basically, even in adulthood, while in other tissues the hedgehog pathway is inactivated, is not working, in the hair follicle, even in adult life, it is important. It has a role also in regulating hair follicle and sebaceous gland. You can see here a patient with Gorlin syndrome. Robert Gorlin described the syndrome in 1960, and he described the syndrome of multiple basal cell cancers, but also craniofacial mutations. You can see the wide nose of the bridge. There are cysts in the jaws, there are like pits in the palms, and also these children tend to develop medulloblastoma before the age of 2. These are the key players of the pathway. You can see here the hedgehog. This is the ligand. The patch is the hedgehog ligand receptor. It's his transmembrane receptor. The signal transducer, smoothened, SMU, and then the GLI, which is activated by smoothened, and is the transcription factor that penetrates the nucleus, the cell nucleus, and activates the target genes for the hedgehog pathway. As you can see here, with no ligand, without the hedgehog ligand, this is the patch. It holds, it keeps the smoothened within the cytoplasm. It doesn't allow it to cross into, to translocate into the cell membrane. But later, if the hedgehog is near, it touches the patch, then the inhibitory effect is lost and smoothened, moved to the cell membrane. Then it activates several intracytoplasmatic protein, and finally the GLI, which penetrates the nucleus and activates the transcription of the target genes. In basal cell cancers, it was defined that there are mutations in the patch, very common mutations in the patch. This is the key disturbance in this malignancy. When patch is inactivated, the smoothing is constitutively activating GLI, and GLI in the activating or it acts as transcription factor constitutively in the nucleus. So the main aim is to try to hold, to stop SMU from activating GLI. And interesting story is that in the 1950s in Idaho, there was a batch of lamb that were born with craniofacial malformations. Some of them had cyclopia, even with combination of the two brain hemispheres. And investigating for the cause of that, it was found that these sheep were having, these sheep during the summer were climbing the mountains and were fed with these plant, the Veratrum californicum. And looking for the extracts of the plant, it was found that cyclopamine, one of the extracts, is the cause for this malformation. This cyclopamine may hold hold patch, and therefore the SMU is activated and causes the GLI to work constitutively. So cyclopamine is the plant extract, but looking at it in the lab, or the compound that we have today is vismodegib, which is much more biologically active. It binds to SMU at the cell membrane, and it prevents the activation of GLI. Okay, and this is the phase 1 trial with 33 patients with basal cell cancer that were treated with different doses of vismodegib. You can see the proof of concept. These patients were responding almost with every dose of drug. Here in the phase 1 trial with complete response of 2 patients and partial response in 16 patients. The registrational study was the AIR events, a phase 2 study that was published in the New England Journal of Medicine. Patients with metastatic basal cell, very rare patient, and patients with locally advanced BCC were treated with Vismo, and the primary endpoint was the overall response rate. Okay. Secondary endpoints, duration of response, progression-free survival, and for some patients, when it was available, the presence of BCC in surgery post-treatment. So this is the publication, and you can see the response rate, the waterfall plot for metastatic basal cell cancer, and for locally advanced BCC, higher percentage of response for the locally advanced, 43% compared to 30%. The median duration of response, this is an update of 18 months that was presented at ASCO 2013 last year, with 60% response rate in locally advanced BCC, and in metastatic BCC 48%, and the duration of response 20 months, 14 months. Some example for the response, which is very rapid, very quick. You can see the baseline at week 8 and week 20, And another patient with a high BCC, sometimes it's very difficult to regard this patient, to define the response in these patients, because this one patient was defined as stable disease because of the scar that remained here. This is a patient with Gorlin syndrome, and you can see the major response. Also, this patient, the face of this patient at week 24, out of 5 target lesions were biopsied and had no BCC. Okay, so this is just to show the response rate at the AIR-EVEN study, the waterfall plot. This is the update from last June, and to show some of more, this case was presented before, and again, this case, not all of them. This patient was regarded as complete response, but the previous one was regarded as stable disease. The drug has side effects, muscle spasm, the patient report, they troubled them during the night, alopecia, disturbance in taste. We have a patient that reported every sweet tastes like sour. They all have weight decrease, fatigue, and nausea. Majority of the toxicity is grade 1 and 2, but there are some grade 3 and 4 toxicity. The STEVI was a kind of expanded access program, a program that enrolled patients with locally advanced or metastatic BCC around the world, up to 1,200 patients that could receive. You can see here, this is the biggest update. This is the biggest cohort of patients that were treated with the Vismo, and the update is for the 300 first patient. As you can see here, majority of them are locally advanced BCC. 22 patients with metastatic BCC is quite difficult to find. As you can see, for the response rates, 17% of complete response, 40% of partial response, and another almost 40% of stable disease. Very minority do not respond at all to the treatment. So, as you can see here, this is a patient with a very big tumor on the nose that was finally resected here. So, for this patient, it was kind of neoadjuvant treatment. This is a taxi driver from Austria that for years was wearing a hat, and you can see the change. Somewhere here, treatment was stopped because of toxicity. And when tumor recurred a little bit, then they restarted the treatment. Also, response in the tumor here penetrating into the skull. And the patient with Gorlin syndrome, you can see one of the side effects here, the alopecia of the patient. This is one of our patients, a patient, 40-year-old patient with the Gorlin syndrome. You can see it here, that's in September, and this is January. She had major response. She had extreme weight loss. She weighs about 40 kilos now. She lost almost all her hair. She refused to stop treatment even for a short time, because for years she had been like 5 tumor resected every month, and now for over a year she has no tumor resection at all. Again, just to remind, the drug has side effects, and as physicians of these patients we have to try to help, whether it's magnesium compounds, to advise to have tumor or treatment holidays from time to time, whether it is for 2 months or 3 months, most probably it is safe. And this is one of our patients that did not respond very well. He had this tumor after several operations. He didn't want to receive radiation therapy, and he started on Vismo. And basically for 8 months he didn't respond that well. We hardly could evaluate the tumor because it was just with MRI to the face, but finally it was quite clear that all this area was even more contracted. And these days he is undergoing reconstruction surgery after wide excision and radiation therapy. And just to remember, this is another option for this patient. Not every patient should receive Vismo. We have to select this patient. This patient, radiation or surgery is not a good option for them. Erivage, Vismodegib, is registered in Israel starting on 2013 for patients with locally advanced or metastatic BCC, especially if they failed, if they had several resections, failed other treatment. Just to summary, this is the first drug that targets the ad-hoc pathway registered for locally advanced BCC. It is needed to select a patient for systemic treatment. Some of the patients will benefit for short course of radiation. We see major benefit in the majority of patients. Very minority do not respond to the treatment, but there is a lot more to learn. Whether alternate, and basically all these issues are addressed now in clinical trials, whether alternate treatment period is good for the patient, of course, for safety, for toxicity, but maybe we have to investigate whether it's connected with resistance. Vismo is neoadjuvant therapy for patients with locally advanced, concomitantly treatment with radiation therapy, and its role in other cancers. There are several studies checking in pancreatic cancer, looking for its role in cancer stem cells, and many other cancers are on the way. Thank you.